She has maximum deficit in the medial cheek area, and there is deficit in the meridional triangle, and maximum projection of the cheek is coming in this area rather than this should be the high point of the cheek. So what I'm going to do, we are going to start from the cheek. Cheek is called foundation coat. So first we always do cheek area, the CK codes, and then we do the contouring, which is done in the temple as well as in the cheek, chin and jawline area. So first we will start with the cheek area, then I will do jawline and chin, and finally we call there are some codes which are called refinement codes. One of them is tear trough, and the second one which we are doing is the lips, and third one which I'm going to do is the meridional triangle. थोड़ा सा पीछे हो जाए, ये जो स्लाइड नहीं देखना नहीं, स्लाइड करेगा, बैक स्लाइड और पीछे ये ठीक। थोड़ा सा आगे जाए, there is too much weight on this. So before we do, I always do the marking, and we should always do the marking. It is very important. So first we mark the zygomatic arch. And the next landmark which we should mark is, in look up, is the lid cheek junction. And the deficit which is present. So our main deficit is in this area which I marked. You can also mark the nasolabial fold. This is the junction between upper lip and the cheek, which is the next junction, that is between cheek and the chin area or the lower lip area. So we mark the meridional triangle, and this is the base of the meridional triangle. This central part is the jowl. We mark the posterior border of the jowl, and this area is the post-jowl region. Same way on the other side, we mark the nasolabial fold, the pre-jowl area. This is the jowl, post-jowl area, zygomatic arch. Can you look up? So we will be working mainly in the medial cheek and lateral cheek first, and then going to chin and jawline. So why do we choose different fillers for different areas? So it is because of the characteristics of the fillers. So as Dr. Tripathi said, fillers could be having different G prime. So G prime is what? Elasticity. So elasticity means if you press anything, it comes back to its shape. That is the character elasticity. Another important thing is swelling factor or hydration, how much water the fillers they absorb. And third thing is cohesivity. So if you put it at one place, does it stay at that place or it moves? So these are the three most important factors we decide when we select a filler. For example, for jawline, we select a product which is called Juvenum Volux, which has got maximum elasticity out of all the fillers and at the same time maximum cohesivity. So that means if I am injecting it along the jawline, not only it is giving maximum projection, also it is not going to diffuse. It is going to stay there and always keep on giving you a sharper jawline. But when I am injecting the tear trough area, I am using a product called Volbella or Volift, which are softer products, because I don't want too much of fullness in the under eye area so that it doesn't look like an eye bag. Lips, I want them to be soft, so I can't use a very rigid product. So again, I will use Volift. But when I'm using in the area of cheek for lifting, there I will use a product called Voluma, which has elasticity in between Volux and Volift. So most of the injections will be done using cannula. Cannula is a long, blunt instrument. थोड़ा सा नीचे हो जाए, ज़्यादा comfortable. Are you comfortable? So cannula is a long, blunt instrument which is like needle, but it doesn't have a sharp edge. So we need to first use an introducer or a needle to create a hole, and then we can use the cannula. So this is the 23 gauge needle. So if I'm using a 25 gauge cannula, I have to use a needle which is 2 gauge bigger, not the same gauge. So if I'm using 23 gauge cannula, I have to use 21 gauge needle. So you pinch the tissue, put the needle slightly rotated and remove it. Put the cap on this. It's very easy to put it when you hold it like this. If you hold it like this, you can still do it, but you need more practice. Once you've been using it for 2-3 years, then you can do it like this. But easiest way is to hold it like this, and then you can change the grip. So this is 1 ml Volift, and my plan is to use 0.3 ml in CK1, which is the zygomatic arch area. And 0.7 ml in the preauricular area. Can you see? Let's turn the head. So I can see the markings here. So 0.3 ml I am using. And then from the same entry point, I change the direction. You can make another entry point, or you can go from here only to preauricular area. So these are called lateral codes, and both these injections, they help in lifting and giving contour or shape to the lateral cheek.
It's not visible. Can we do it from this side?
It's difficult to treat from the left side because I'm a right-handed person. I can just stay back like this. I try to stay
It's okay now.
a little away from the patient. So we finish 1 ml. Then you can do little molding so that it spreads evenly. Now I am using Voluma again, doing the medial cheek. I generally go from the same entry point. Some doctors, they use a separate entry point from below. So now I am in the deep fat pad. This is also called deep medial cheek fat pad. So in this region, the most important vessel is infraorbital artery. We have to take care and always keep moving the tip of the cannula. We should avoid using needle in this area.
So at what depth we are?
We are in the deep medial cheek fat pad, which is just above the bone. So you've seen I lifted the tissue and went very deep. So that's
Just
how we,
above the periosteum.
just above the periosteum. So that way we have filled the deep fat pad. So now we have done the deep medial cheek fat pad with half ml of Voluma Bolif. Though sometimes we do tear trough later on, but since we don't have much time, I'm doing the tear trough at the same time. Now I've changed my syringe. Now I'm not using Voluma, I'm using Gold Lift, which has 17.5 milligram HA per ml, and it's a much softer product. You can also use Volmella in this area. Can you open your eyes and look at the roof? So now I am treating depth again. It is, see, whenever I am using cannula, most of the time I am in the supraperiosteal plane, that means in the deep medial cheek fat pad. In the lower half, it is called deep medial cheek fat pad. But when I am treating tear trough, then the name of the fat pad, it changes. Here it is called SOOF, suborbicularis oculi fat pad. So I am injecting in the area of SOOF, again very deep, because I don't want any tindal effect or any irregularity.
If it is quite superficial, then it will lead to tindal effect. Tindal effect is, what is the tindal effect?
Tindal effect we all studied in physics. Tindal effect is when light gets trapped in a liquid, so it becomes blue, like sea. Sea water is not blue. It is just because the light gets trapped in sea water. As you go deeper, it becomes blue. If you come to the shore, it is like normal water. It is salty. So same way, if you put too much filler at one place, especially in the under eye area where skin is very thin, so So you must have seen a lot of people having bluish discoloration. So that is called Tyndall effect. Tyndall, Tyndall effect. So to avoid that, we place the filler very deep so that light doesn't go and get trapped in that. Can you say that?
Dr. Vishnu, sir, although we used Pralox in this patient, so do you do something else also to alleviate the pain of the patient in addition to Pralox?
Yeah, we give a stress ball to the patient always. Sometimes two if the patient is very nervous. In between, if I see sweating on her face, I take a break, give water, and that's it. But generally with cannula, because if you're seeing, I've done 4 areas, all through only single entry point. So there was no other break. So we could do lateral cheek, preauricular area, tear trough, medial cheek. And if you can see, I use just 2 ml of filler. And maybe I'm not sure if it is visible here, but if you see directly, there's already a huge difference in her face, in the cheek contour, and especially the sagging which is happening on this side is improved with just 2 ml. And now we are going to move to the next area. Please lie down.
Do you use blocks, sir? No.
I never use block.
I always ask the patient about the choice of her music. And I play some soft music, or even if she likes ghazals or even Punjabi songs. So that is one. Second is regularly communicating with the patient. Keep on talking to the patient. But tell her not to speak, but just keep on talking to the
They are listening to the music. And of course you can talk to them regarding their daily affairs and other stuff, the vacations which they have taken recently. Next we are moving to the chin area. As I said, that is a contouring area. We did foundation, now I'm going to contour. We are not doing temple, so I'm starting with the chin. This is one area I would like to do with needle. So this code is called C2 code. So I go deep on the bone, aspirate, see if there is blood or not, and then I inject. So about 0.2 ml here. It's like surgical implant. Many people believe in putting subcutaneous chin filler, but I prefer doing supraperiosteal because as surgeon we know that the cheek shape we can change, relax. By injecting on the bone. It just mimics the cheek implant. So this was Bolex. So I'm changing the needle. Then adding a little bit on both the sides. This is called C3 code. Again aspirate and inject. On this side also aspirate and inject. I still have some left in my syringe. So what I can do with this? Another area where I use needle is freeze out area. aspirate, inject. This code is also called JW4 code. It's a jawline code. So we have done the chin part and pre-jowl area. Now I am doing the post-jowl area. Bullets. This is again one area. Sorry for that. Again, I inject with the needle. First, identify the jaw angle. So this is the jaw angle. Go on the bone. Aspirate and inject. When the aging happens, the first thing you see, the blunting of jawline happens at the jaw angle. So normally our face is separated from the neck by the jawline. But as we age, it starts becoming one near the angle. So first thing is to put it separate. So to make it separate from the neck. Yeah, take it. Same way I go on this side. Find the angle. Go on the bone. Aspirate. And inject. So on both the sides we've injected 0.25 each. Now I take cannula. Give me another cannula. So I'll make a small entry point here. So again, we make a pinch. So we have published 2 papers on pinch anatomy of forehead as well as of temple. So if you read them, you will understand the importance of using pinch while doing filler injection anywhere on the face, be it temple or forehead or cheek, everywhere. Pinch has a great role. Please turn this side. After this, I am going to do the Meridian triangle with bullet, which is a softer product. It's already. And make an entry point here. And another one for the other side here. This is now, I'm doing, this is one area where we do subcutaneous plane, not supraperiosteal. So this is superficial fat layer. So this code is called C6 code. This is different from? Basically, we are covering the depressor angularis. We are putting it on top of depressor angularis.
So, are we dealing with the static lines?
So, yeah, we are basically treating the meridian triangle. So I have marked the outer zone, so I am staying inside this outer zone of the meridian triangle.
So is it subdermal or subcutaneous?
This is subcutaneous plane. Lastly, I am going to use cannula for lip filler injection.
So is it safe to inject in subcutaneous lane? Earlier we used to inject supraperiosteal.
Yeah, so there is a concept called myomodulation. Myomodulation means if you inject under the muscle, you are strengthening the muscle. So when we are treating the areas where we want to strengthen the elevators, like cheek area, we go deep because we are supporting the muscles which are elevating the mouth corner or cheek. When we are working in the perioral area, then we are putting it on top of the muscle. We are loading the muscle. So which are the muscles which we load? DAO and mentalis. So as I mentioned, if I have to give shape to the chin, then I go deep as I did in her case because I wanted projection. But if a person has very strong mentalis, then at the same time I also do subcutaneous filler in the subcutaneous plane to do myomodulation. So it reduces the power of the muscle. Also it acts as a sort of a barrier between transmission of the muscular movement on the skin. So by thickening that plane, you are making that area look smoother.
To avoid vascular complications, it was supposedly said that either you inject subdermal or you inject on the periosteum. That's the safest rules.
The subdermal is subcutaneous.
Yeah, so that's what he was saying. He was saying subdermal. Not into the bulk of the soft tissue, just subdermal or maybe supraperiosteal. That is where you'll have the least complications of vascular issues.
Yeah, in the face, most of the vessels, they run closer to spars. Whether it's facial artery or its branches. So in this area we have inferior labial artery, which runs under the DAO muscle, and then it becomes superficial and it runs on top of DLI muscle. So when I'm injecting marinate triangle, I'm on top of the DAO, so artery is under the DAO. So if I stay in subcutaneous plane, I'm safer. But the moment I cross the medial boundary, go in the mental crease area, that's the area where artery is in the subcutaneous plane, I have to use cannula and not use needle in that area. Now I'm doing lip. Again, I will do it using a cannula. Most people use needle. We can use needle or we can use cannula. In people where there is major volume loss and you don't want too much definition, yeah, it will be very, very simple. So I've taken more left. Very gently move it to the midline. As she wants very subtle change, I'm giving only 0.15 in this side, and from the same entry point I move it in the lower lip, again reach the midline, and the advantage of this technique is there is no lump, no risk of bruising, the risk of vascular complication is extremely low. And I can also add little bit at the corner.
So what is the plane of injection? It is under the muscle.
So basically under the mucosa, there is a subcutaneous plane, subcutaneous fat plane, and then we have orbicularis oris muscle. So I am placing my filler in the subcutaneous plane, that is the only expandable plane in the leg. If I go into muscle, I am causing pain, bruising, vascular accident. If I am too much superficial in the mucosa, I am causing lumps. So you have to find a sweet spot where your cannula is going very easily. Can you sit down, please? And you can see it's a very natural fullness of the upper as well as lower lip. It's primarily because I use only 0.3 ml, 0.1515 in each quarter. So it mainly gives hydrated and fuller look without changing the shape much. Now I quickly finish on the other side. It's like that. We are almost done. I am going to take 5 more minutes to finish the fillers. Again 0.15. And I flip it into the upper lip.
part is not visible. So is it along the vermilion border, sir?
No?
It's not visible.
Is it
Along the vermilion border.
No, थोड़ा नीचे देखिए नीचे. It's not along the Vermilion border, it's in the middle of the Vermilion zone. If I have to do Vermilion border, then I prefer using needle if I have to create a border. In volume there. It's very important when you are doing multiple syringes, always write down your plan on a piece of paper. Otherwise you end up having some extra filler and then you forget which area you were injecting what. Because we are using 3 different products. And this one. Left side I do while standing on the right side because I'm a right-handed person. And to do the lateral part of the face, I stand on the right side. So again, if you see I'm using a pinch to go in the depth, 0.3 ml, in CK1, and 0.7 ml in CK4. So that way we create the lateral lift. Now the medial cheek is left and the teardrop. So what have I got from the right side? Half ml of Voluma and half ml of Volift. Because before starting the treatment, I had written my treatment plan on the tablecloth. So I knew exactly where I'm injecting what and in how much amount. And using the same entry point, again going in the deep medial cheek fat part. So half ml of Volima, and finally the last half ml is for the tear trough area.
The different product in the theater of area.
Yeah, we used Juvidum Bolif. It's a softer product. We can use Juvidum Volbella also. But right now we have Juvidum Bolif here, so I'm using it. Lateral cheek and medial cheek we used Volima, but here in the under eye area I'm using Bolif. It's the same product which I used in the marinade as well as in the lips. आप अब छत की तरफ देखिए. Again staying as deep as possible to avoid tintal effect.
So what are the post-injection precautions or care patient need to take?
After injection, basically they are supposed not to do heavy gymming for 24 hours, not to use any sunscreen or lipstick. Do you have some news for him? Yes, yes. And no makeup for till next day, like till tomorrow morning, and she's not supposed to wash her face. And
Do they need oral antibiotics?
no, they don't need it. We don't give oral antibiotics.
If the patient is diabetic, do we need to give any antibiotic?
No, if it is under control, there is no need to give. We take all the aseptic precautions, and generally you don't need antibiotics.
If by chance excess amount of product injected, is there anything to reverse?
Yeah, if excess, it is not like if there is some complication, like if there is lump or if you inject excessively, then obviously you have to dissolve oil in that area. So we can use hyaluronidase, but generally we use it in complication. If there is overfilling, you want to reduce it, or if there is vascular episode, or if there is any delayed onset nodule or inflammatory nodule which is there. These days you must have seen a lot of actresses or actors, they have overfilled faces. So if you want to reduce that, then we use hyaluronidase. Some people say use RF, this, that. I don't think it works. RF doesn't work. Because with RF we can achieve a temperature of only 43 degrees max or 44 degrees. Whereas fillers, Juvidum fillers, they are autoclaved at 130 degrees for 30 minutes before packing. After they are put in the syringe is autoclaved. So I don't think 40 degrees is going to do anything.
Any questions from audience?
Before we do Botox, let's quickly have a look at the final outcome. Can you please say? You can very well see she had very tired look and saggy look, sad look. So all those characters have improved, the negative attributes. And just look at her lips. I always say lips are the cherry on the cake. You should always do lips. If patient doesn't want pouting lips, still do. Only if, like we've used only 0.6 ml, which is like half syringe. but that half syringe has made her lips look so fuller and youthful. Because with age, even if somebody has reasonable sized lip, with age the lips they lose fullness or turgidity. Here we have given that turgidity or fullness back to her lips. And you can see the meridien triangle, and this also has improved. And if you see the jawline, which is quite saggy, there was jowling here, now it's almost straight. If we draw a line from the lower lip, the chin is almost at the same level. Earlier it was protruded. Yeah, this hollowness on the side we keep it. Although I did pre-auricular area, I did the upper half of. And it is very important that the wire should have a vacuum. You just push the needle and leave it, and water will go inside. So if there is no vacuum, don't use it and return it. Vacuum means that this is a sterile and perfectly packaged unit. After that, you detach the syringe and leave the needle for a few seconds. There is so much negative vacuum, it's difficult to fill the syringe later on. So, but if you keep the needle for a few seconds, the vacuum is broken. And that's still slippery. So now I am filling it. So this midi syringe, every mark is equal to 1 unit because I have used it 2.5 ml dilution. So 12 units in the forehead, in the frown area. In this area, this is not very painful. So here is the muscle which is procerus, which starts from the nasal bone and inserts into the dermis, which is horizontal line. So I am giving 4 units here, 4 units in the corrugator. Again, medial end of corrugator, 4 units. So total 12 units I have given. 8 is less. It's very natural.
Because I haven't taken the consent to have been, he's not in favor of this thing.
See, the normal dose is 64. I'm giving 50 units only. I'm underdosing it. So don't worry. But your friends will love it. It's my experience that husbands don't look at their wives so minutely. Huh? Lateral corrugator. So medial corrugator you go deep, lateral somewhere in between, because corrugator is a muscle which rises from superior medial corner of orbital rim, and it starts in layer number 5, but then it traverses layer number 3, which is frontalis muscle, and inserts into dermis laterally. So as we go lateral, we need to stay more superficial. Medial most is the deepest, layer 5. In the middle is layer 3, and if I need to give for the tail of corrugator, then it is given interdermally. So most people teach you have to inject like this. That was initially idea because If patient moves, the needle should not hit the eyeball, but you can go like this or like this, whichever way you want. So 3 points injection, central, superior, and inferior. We can inject on the other side, standing here. This asks the patient to turn the head, feel the orbital ring.
Sir, how far it is from the orbital rim?
It's about 1 to 1.5 centimeter from the rim. The lateral spread of the toxin is 0.5 centimeter or 5 millimeter all around. So if you are giving it 1 centimeter, it will come back only 5 millimeter. So it's pretty safe.
If injected closer, then it will lead to complications like
Pardon?
if it is injected closer to the
Yeah, if it is injected closer or if you're using a product which has got higher diffusion capacity, some cheaper version where the protein binding is less, so their diffusion circle is more. Sometimes it goes and impact the extraocular muscles and may cause squint or diplopia. So one reason I'm very fond of Botox is I know it spreads only 5 millimeter. So it gives me more precision. So it's not about any toxin might be effective, but whether it is working in that zone or not, that varies from one to other toxin. Can you raise your eyebrows? So her left eyebrow is moving more. So that we have to take care so that she does not get a Spock eyebrow. So I give slightly lateral than normal. Two units at 5 points. So we use 20 units for from, 10 each for crow's feet and 4 headlines. So that completes our treatment.
so how to prevent that smoking?
Spocking in some people, the frontalis muscle doesn't stop at temporal crest and it extends into temple. So although name is frontalis, but it becomes temporalis. It goes into temporal fossa, and if people have that thing when you raise the eyebrows, that means if you treat the forehead, the outer part will become overactive and patient will get Spock eye. Then the M pattern, you have to expand laterally. You have to go more laterally so that spocking do not happen. Don't just stop at the temporal crest.
Spock is a fictional character where the lateral eyebrows then raised in comparison to medial eyebrows. So that is
So when we were kids,
part of complication.
there used to be a series called Star Trek. So in that there was a character called Mr. Spock, and his eyebrows were very peculiar, ears and eyebrows. So eyebrows were like very sharply raised. So it is also called Mephisto's sign. So I think she's looking very pleasant. Okay.
Thank you.
So first we do the marking in her case. Can you smile? You can see these are the crow's feet line. First I mark the central point, then 1 centimeter, 1 to 1.5 centimeter above, and 1 to 1.5 centimeter below. Same way, if you look on this side, central point 1.5 centimeter below and about 1 centimeter above. And this way you mark 3 points. Then can you frown please? Yes. So if the patient cannot frown, you can use your other hand to pinch it like this. This is the procedur's injection point, and this is the corrugator injection point. They have to be like really close to the orbital ring because muscle is originating from the orbital ring. So your point should be along the ring, not along the eyebrow, because muscle is arising from the bone. And then can you raise your eyebrows? So you mark the zone of the muscle and one central point, two lateral points. So these are the 5-point injections which we are going to do. Any questions in between while I am filling the syringes? If there are any questions, you can ask Dr. Tripathi.
Questions from the audience? Any doubt regarding the fillers? Please. Sir.
For a few months we had interaction with some other people. They told us don't go close to this supraorbital margin because of the danger of fluorosis. And your comments on that?
It has to be within 1 centimeter. If you go beyond 1 centimeter, then you are injecting in the frontalis. So it should be somewhere in the 1 centimeter zone above supraorbital rim. Best is to feel the belly and show you how to do that.
Any more questions? You should know the exact points where to inject, exact amount, and the site of insertion, plane of injection, all these things you should know.
So I'm starting with the frown line. Procedures, then the corrugator. ठीक है? Then in the forehead, in the midline. 2 lateral points. And now the crow's feet. So that ends the treatment for her. So we used 50 units in her. So it was a 100-unit vial, we used 50-50 in both the patients. How was the pain? Karnal?
Yeah, little bit.
You need some water?
Little bit.